If you support families with infant feeding as a lactation consultant, SLP, therapist, doula, or other provider, you won't want to miss this. I'm Lisa Palladino, certified nurse midwife and IBCLC, and I'd love to invite you to my free 3-day video training. Why tongue tie is missed and how you can learn to spot it with confidence. In just a few short videos, you'll gain the clarity you've been craving around tongue tie, what to look for, why it's often missed, and how you can better support the families in your care. It's free, flexible, and made for busy professionals like you. Sign up now at tonguetieexperts.kit.com/free. That's tonguetieexperts.kit.com/free. The clickable link will be in the show notes. I'll see you there. You're listening to the Tongue Tie Experts podcast, a weekly program providing information and support for those families impacted by tongue and lip tie and the professionals caring for them. I'm Lisa Palladino, a midwife and a lactation consultant with over 30 years of experience. If you are a parent looking for answers or a professional who is curious to learn more than what you learned in school on this topic, welcome. This podcast is for you. Hi, everyone, and welcome back to the Tongue Tie Experts podcast. I'm your host, Lisa Palladino, and on this week's episode, I am very excited to have one of the dentists that's right in my neighborhood, and I had no idea for many years, Dr. Steve Acker. Dr. Acker is a specialist in airway health and guided growth and development. Welcome, Dr. Acker. I'm so excited to have this conversation with you.
Yeah, it's my pleasure. I'm happy to be here and happy to be doing this and getting more collaboration and reaching out to people in our community so they can learn more about this. Yeah.
Yeah, so we are both, I just moved to New Jersey, but up until a few months ago, we were both residents of Staten Island, New York, which for those who don't know, Staten Island is a very unique place, geographically part of New York City, but a little bit separate, a little different as far as accessibility to healthcare professionals. So we don't usually get someone who's as expert as you are in our area, or if we do, we don't know about them. And that was the case. I didn't know you existed, which is crazy. Yep. And we met at a conference, the PANI conference in Long Island. So I had to go to Long Island to know that you were down the block. Isn't that strange? Yeah. So, and now we have a local group called the Airway Roundtable where we meet and we get together every couple of months with other professionals, which is part of my mission is to get people all over the place to make groups like we did so that we can learn from each other.
Yeah, there's great power in that, and that's the collaboration and the interdisciplinary results we've gotten have been pretty amazing.
Yeah,
a good community. Yep.
It is a good community and really caring and impressive individuals in that group. So, Dr. Acker, tell me how you went from being a general dentist to someone who's looking and thinking about airway.
It's interesting. A couple of different things happen simultaneously. I still do a lot of restorative dentistry, a lot of implant stuff. But I've been involved in the academic aspects of dentistry for my entire career, in addition to private practice. I actually have I still have a teaching position at a hospital in Brooklyn, at Brookdale Hospital. Mm-hmm. And I've been involved in a really high-level dental education center out in Seattle called the Coy Center for the last 25 years. Mm-hmm. So between those two things, I've had an academic handle on things. And myself, it's kind of a personal story. Myself, 25 years ago, I was diagnosed with atrial fibrillation. Wow. Out of the blue, perfectly healthy athlete, everything like that. And I was referred to an amazing electrophysiologist on Staten Island who retired during COVID. She was in her mid-80s already when she retired. Wow. But I met her and I was referred to her, and she managed my AFib. And then basically I had an ablation done 22 years ago now, and I've been fine ever since. But even before it was in the literature, she basically said, all of my healthy heart AFib patients have sleep apnea. Go get a sleep test.
Wow.
And I knew that I snored. I didn't know what it meant.
And this was 22 years ago.
23 years ago.
People who say that this is a new field, they're not telling the right story.
No, and she knew it, and she said, and now it's all over the medical literature in major ways. So what ended up happening is, in addition to that, just about at the same time, one of the other doctors I know from the Coy Center in Seattle had a study club that she was starting. She practices in Northern Virginia, and she invited me to attend. And one of the speakers there was Steve Lamberg, who has a patented dental appliance, oral appliance for managing sleep apnea that he even had at that point. This was going back 2008. And so I heard him speak about it. I learned about it. He actually trained me just to how to manage appliances and stuff. And I was one of the first patients for myself.
Wow.
My partner in life, Nancy Hartrick, is a dentist. Also, I met her out in Seattle a bunch of years ago, and she made me my first oral appliance back then. And then we learned logistics of how to integrate this into dental practice. So I did that, and then it just got, because I'm an academic person, got much bigger than that. We wanted to look at why did this happen, what was the root cause, and when did it start. And going through all this, we learned that it started often prenatal and always in infancy, and it was all about guided growth and development of the child that made them more predisposed to have these issues. And that's where it took us. So that's how I got into this, and it's a significant part of our practice. And at first it was treating adult patients that had sleep apnea with dental appliances, and now I see as many kids as adults to help, but with the help of lactation consultants, myofunctional therapists, craniosacral therapists, speech and language pathologists, sleep physicians. So we have to collaborate. It's a multitask situation, but often we find that we're the quarterback of it, and a lot of the things that we do in practice are treatments that help kids as well. So that's how it all started.
Wow. So I just have to mention, when you said you had AFib, I'm thinking to myself, I come from a family with a very strong, not good cardiac history. Let's put it that way. And stroke runs in my family and in so many families, right? Especially in the community that we live in.
Right.
And just thinking about how many people who AFib comes from stroke, or stroke is caused by AFib, because you can throw a clot, right? So I'm just making that connection. Imagine if we had prevention of sleep apnea, how much less stroke and neuro problems we would have, not even just cardiac, but just the neuro problems down the road. That's something I hadn't really, I know it's good for heart health, but I hadn't really made that connection with the AFib. That's
so here's interesting. There was a large study done in Europe in 2016, and it looked at different comorbid medical conditions and their relationship to sleep apnea. And the statistics were shocking, actually. 91% of nighttime heart attacks and strokes are in patients that have untreated sleep apnea. 91%.
Wow.
Way greater than half of atrial fibrillation are in people with sleep apnea. So the question is, well, how does this happen, and why does this happen? And it basically happens when our protections and our compensations are no longer working. When we're sleeping at night, throughout our entire airway, there are little things called mechanoreceptors. They're like mini computer chips. They're right throughout our pharynx, even to the top of our lungs. And when there's a collapse of an airway or turbulent airflow coming in, it's a protection that nature's given us. We trigger these sensors. They send a signal to our brain, which then sends a signal to our adrenal glands. Wake up, you make cortisol. That's the fight or flight hormone, and we're having an arousal when we're sleeping to protect us. It's when those centers get burned out and we're no longer protected when people have nighttime heart attacks and strokes. And people that have these apnea issues for a long enough period of time don't have that protection anymore. But that protection also comes with consequences. Overproduction of cortisol at night is inflammatory. it's
Mm-hmm.
unhealthy, and it's
Mm-hmm.
part of our fight or flight or sympathetic nervous system. That system is supposed to be shut down 85% of the night. We should be running on our parasympathetic, our rest and
Mm-hmm.
digest system. And in patients that have sleep disorder breathing, the reverse happens.
Right.
So
And
all the
yeah, and that
consequences.
interacts the adrenal, because I know this from my
Right,
functional medicine training.
right,
The adrenals interact with the thyroid, with the hormone systems, with
everything.
the regulation of obesity, and it's all
The,
intertwined.
the,
And
the, the consequences are enormous. So
yeah,
just the simple ones, patients that have sleep apnea often grind their teeth at night. It's another protection. It's
hmm,
called, now they have terminology, rhythmic masturbator muscle activity, RMMAs. It's actually a movement disorder that's a consequence of it. Laryngeal pharyngeal reflux, heartburn,
right,
happens as a result of sleep apnea.
right.
ADHD-like behaviors, especially in kids, from
Hmm.
sympathetic being upregulated all the time. So all these things are
Yeah, and
consequences of
anxiety. I mean, so many
anxiety.
young
Yep.
adults now are suffering with anxiety, and it's
Yep.
probably related to sleep. And I think it's an inverse reaction to how much stimulation we have from our phones and always
Oh,
being
I
connected,
think
right? And
I think
then,
it's all
and
a complication of that.
yeah,
Yep.
yeah. And yeah, that is really fascinating. And the other thing that you have said that now today I'm on an interview. This is my interview day. So this is the third interview I've done today, and everyone I've interviewed has said we have to ask why. And geez, I didn't learn that in my medical training. You probably didn't learn that in your dental
No,
training, right?
no,
This is to me the
no.
theme running through everything. Root cause, why is this happening? And just keep saying, well, why is that happening? Well, why is that happening? And finding that root cause and fixing that other than just putting band-aids on everything, right?
The functional physicians who are looking at root cause have really been our prototype for what
Hmm.
we're doing. We're
Hmm.
looking for root cause.
Right,
We're understanding how it happens. We needed to know why it happens, and
right.
it's all related to growth and development and what we call oral volume.
Uh-huh.
The amount of space in our mouth, which usually relates to the space in our airway, and it's the space for our tongue. And our tongue is the growth center for our upper jaw and for our face. And
Mhm.
we didn't we realized it, but didn't realize that we didn't know how profound it was.
Mhm.
So the things that nature has told us we should be doing, like breastfeeding our kids and having them chew solid foods, even starting at 5 months old, these are all things that aid in the proper growth and development of the
Mhm.
child.
Yeah.
And the reason that is the tongue generates about a pound of force, about 500 grams at rest. It belongs resting on the roof of the mouth. We belong breathing through our nose with our lips sealed. When
Mhm.
babies have their tongue on the roof of the mouth, and children right up until the ages of adolescence, the jaw grows forward enough and wide enough, and there's plenty of space for the tongue, so it's not back in our airway when we're lying down and going to sleep. So we don't have crowded teeth, narrow palate, high
Mhm.
palatal vault. All those things are part of the root cause. Understanding it are the consequence of the
And
root
if you
cause.
think about the generations now, there's a couple of generations of people who've had orthodontic work where their teeth were removed. I'll raise my hand. I'm one of them.
Me too.
So many teeth removed, and our jaws were made even narrower. Our palates got even higher than they would have been if we were left alone with our
Yes.
crooked teeth, right?
Right. So perhaps I was predisposed to sleep
Yeah,
apnea anyway because I had
yeah,
crowded teeth and a small jaw. And
yeah,
then instead of the direction of treatment being to expand me, they took teeth out and pushed me
yeah,
back. And then I was dead in the water.
right.
That was it.
And now you mentioned in utero. So I had a conversation with Dr. Kevin Boyd about this.
One of my mentors,
Yes, and
amazing
Kevin
guy.
is brilliant. I just saw him
Yeah.
last week at a conference, and another always a fascinating talk. No matter how many times I see him present, it's always something new and makes you think, right? And but he keeps mentioning, I keep hearing in utero, and as a midwife by training, and as a lactation consultant, sometimes I feel like, well, if it's really in utero, it's a little frustrating because you can't go back and fix things. But what could we be doing for pregnant women to make sure this doesn't happen? And going back to my own history, my mother smoked while she was pregnant with
Me
me,
too.
right? So is
Right.
that the connection? I would love to see a study of smokers. I know I'm smaller than I should have been. I mean, my family is all small, but I was 3 inches shorter than my mother, which is not how things usually work. I was a very small kid, and you've met me in person. I'm still kind of short, and I shouldn't have been. Like I had growth retardation in utero, and is that related to airway? And why wouldn't it be, right?
Yeah, why wouldn't it be? The thing that's really interesting is we now know, and there was there've been studies even in the last few years that greater than 50% of women during pregnancy have sleep apnea during pregnancy, sleep disorder breathing, even if they didn't have it without being pregnant. So transient hypoxia, low oxygen levels to the baby, to the fetus, have effects in terms of the activity of the fetus and growth and development there. So there are definite consequences there. So the recommendations now are for especially starting second trimester on, to give a pulse oximeter or something to your pregnant patient to see if there's any desaturations going on. And if there are, even if they have to, for a short period of time, have a CPAP machine or something like that, then it's good for the fetus,
right.
Or a dental appliance,
just to get them over that hump.
So they don't have transient hypoxia is not good for a fetus for sure.
Right. Yeah. And, I'm thinking of a pregnant person I know right now who doesn't have a good airway to begin with, and it makes me worry. Yeah. So, and then of course, breastfeeding. And when I started out being an advocate for breastfeeding, I was thinking all about antibodies and, nutrition and all that, which is all important.
Certainly. Yeah.
But now it's more about
function,
growth and development of the airway. And it's really hard for people who don't understand the downstream effects of this. It's harder for me to make that point. Like, no, just give a bottle isn't going to help. And not to make anybody feel guilty, right?
No.
But giving a bottle is not going to help the airway develop properly.
Right. And it's interesting. There were basically two generations of people where breastfeeding, at least in the U.S., became not in vogue. My generation, my parents didn't even think about it. And my kids, basically same thing. And those are the ones that bear the first consequence of that. And even secondarily, in those same two generations, we had something called baby food.
Yes.
Which has no purpose on this planet. And the new concept, which is certainly not a new concept, but baby-led weaning. I mean, it's an old concept, but having infants start solid foods at 5 months old, cutting things in strips and making them chew and use the musculature and use the tongue, that creates way better development of the bony structures and stuff like that as well. So,
we've developed a culture of fear. So in that sense, we're afraid that the baby's going to choke. And there's a difference between choking and gagging, right? Babies should gag because that's how they learn how to eat. But when we see gagging, we get nervous, right? And there's that, there's a lot of fear-based practices that came into vogue because, and again, convenience.
Yeah, and again, nature was so clever when they put us together. I mean, before 9 months old, the larynx is above the epiglottis. So you really can't get food into your airway until you're after 9 months old. So the toddlers are way more at risk of choking than infants are. They're not going to choke.
That's interesting.
So,
and also, babies can breathe and swallow at the same time up to a certain point, too.
For the same reason.
Yeah, that's kind of
for the same reason.
Yeah. So the baby-led weaning is going back to how it's supposed to be, meaning sharing your food with your child.
Yes.
But that requires that you're eating healthy food. Many of us are not eating food we would share with our baby.
But the concept of baby-led weaning is to eat things that you have to chew, and basically that's not processed stuff.
Yes.
So the goal is not to give our kids or ourselves a lot of processed food. Or any processed food, if you ask me.
Because everything we eat is soft, right?
Yep.
Kids are sucking pouches and drinking smoothies and all the things. And then if you support families with infant feeding as a lactation consultant, SLP, therapist, doula, or other provider, you won't want to miss this. I'm Lisa Palladino, certified nurse midwife and IBCLC, and I'd love to invite you to my free 3-day video training. Why tongue tie is missed and how you can learn to spot it with confidence. In just a few short videos, you'll gain the clarity you've been craving around tongue tie, what to look for, why it's often missed, and how you can better support the families in your care. It's free, flexible, and made for busy professionals like you. Sign up now at tonguetieexperts.kit.com/free. That's tonguetieexperts.kit.com/free. The clickable link will be in the show notes. I'll see you there. The other thing, and this is more of a structural issue and not really, in your scope, but when we think about the Back to Sleep campaign, where we're all afraid to put our babies on their bellies, and babies need to be on their bellies in order to develop the musculature of the head and neck in order to lift up and have good extension. And that's stopping. We're getting different head shapes because of kids putting, I just thought of that in the same fear-based society, the baby, the giving purees, not baby-led weaning, and the way we make our babies sleep. And anyway, but we, one baby at a time, one family at a time.
Yeah. The other thing that we, in this country, the model of orthodontic treatment really violates the growth curve. Mm-hmm. We know that the exponential growth, the most rapid growth of the face, the jaws, and the teeth and airway and everything else happens between birth and 9 years old. So 80% of the growth of the upper jaw, which is the housing for the tongue, and the lower jaw happens by 9 years old. So the concept in this country of doing phase 1 of orthodontics at 8 or 9 years old misses the boat.
It's too late, right?
It's too late. But not so in Europe and in Australia, where functional orthodontics, whatever you want to call it, functional training, yes, they intervene early on, at 4 or 5 years old, and the things you can do it even with a 4-year-old that's on this bad path are so much less invasive and so much more profound and easy than it is when you have a kid that's 10 or 11 where you're kind of locked in. Mm-hmm. So yeah.
Yeah, and do you know if they're having better outcomes as far as when those kids grow up? Like, has there been enough time passing as far as airway disorders decreasing and less?
Yes.
That's really interesting. Yeah.
Yep.
So at what age do you start with? Do you use orthodontia in a different way in a small child? Tell me about that.
So what our protocol basically is for the first 4 years of life is getting the child to function properly. When you talk about pacifier use, you can go back to that. So you have adult swallow and you have infant swallow. You convert from infant swallow to adult swallow somewhere between 9 and 18 months, different for every kid. Mm-hmm. So we know that sucking is normal for infant swallow, but it's not. It's a dysfunction for adult swallow. Mm-hmm. So in terms of pacifier use, we basically say we don't love pacifiers, but if you're going to use it, it's proper function till 9 months old, then you got to get rid of it.
Yeah.
So there are products on the market, again from Australia, something called a myomunchie, which you've heard of.
Yeah, I'm very familiar. I have a myomunchie.
Yeah, which we actually, all of our patients between 2 and 4, healthy and non-myomunchie. First just to chew on, and then when they get to the age of cognition, about three and a half, depending on the patient, having them put the myomunchie in their mouth, seal their lips, and be able to keep their lips sealed for 15 minutes with the myomunchie, and that means you're breathing through your nose and your tongue's up.
Wow.
So that's from 2 to 4 years old. And at 4 years old, if we see there's not proper growth and development, there are even what we call primary pediatric aligners. They look like Invisalign aligners that you can use when the patient's fully in baby teeth, so before 6 years old. But if you see that the development is not proper and the back teeth and there's no space between the front teeth, there should be space between baby teeth where you can stick a nickel between each tooth. And if the back teeth are tilted inwards, then primary pediatric aligners is a great thing. And the kids, they change them every 5 days. They're in increments. And the kids wear them 24/7 as opposed to Invisalign. They sleep, eat, and do everything with them. And
Wow.
the kids like them because they feel better when they're using them. So, that's an early adjunct. And it's actually not orthodontics, it's orthopedics. You're actually growing the bone.
Right.
The aligners go a little bit longer over the teeth, about 3 millimeters onto the gums. And because they're driven functionally and you're having the patient function on them, it's orthopedic remodeling is what you're doing.
Wow.
Yeah. So
that's fascinating.
So that's something fascinating. And then you get into, after when they start losing their baby teeth, you can't use the aligners because you have teeth coming in and out. But you can use you can use expanders, you can use functional appliance systems like MyoBrace and Healthy Start. Because they force proper function, they help with proper growth and development as well. So these things can all be done before the age of 8 and 9 when 80% of that growth is done. And that's what we look to do. But it's not just structure. It's structure, function, behavior.
Right.
Yeah. So function, tongue on the roof of the mouth, lips sealed at rest, nasal breathing, and breathing behaviors, not hyperventilating, so you have poor tissue oxygenation. So it's structure, function, behavior, all equal circles.
And being able to move the tongue, which is where the myofunctional therapy comes in, and good tongue function and strength. And that's what helps further form those bones.
Right.
It all makes so much sense.
Yeah, those are anatomic factors. And then there are non-anatomic factors, such as some patients have over-responsive sympathetic nervous systems and stuff like that because of the vagus nerve. And craniosacral therapists are wonderful at being able to mediate that because it really helps stimulate the parasympathetic nervous system. Little kids can't meditate, but they can have myofunctional therapy and cranial osteopathy.
Yeah. Do you know what's fascinating? I don't know if I've spoken about this on the podcast yet. I just finished Invisalign. I'm on the retainer phase. And when I first got the Invisalign, I didn't think I was going to be able to do it. It was stimulating me. It was just activating me so much. It was making me nervous. So I went to our friend, Christina Goodhart, who's craniosacral, and I went a couple of treatments, and she told me what to do when I wasn't with her. And that's what got me through that beginning, because that's exactly what was happening to me. My vagus nerve was, I was just totally overstimulated.
Right.
And I was grinding to keep it in. And I was, not to get too, personal, but this is a firsthand example of how something as simple as craniosacral therapy can really make the difference.
Yeah. And, when kids or adults, but especially when infants or little kids have really tongue restrictions and tongue ties and lip ties and have to have revision done even with a laser, we insist on them having craniosacral therapy before and after. And the parents will tell you it makes a profound difference.
Yeah. And even sometimes Christina can treat during the procedure.
Yes.
Which is just
we do. Yes. Yep.
Yeah. So we're so fortunate in the professionals that we know. And then as you were talking and mentioning all the different appliances, I am so impressed with the technology that's coming out now and how many there are options, right, to different types of appliances, and because there won't be a one size fits all.
No,
for every patient.
No, there's a lot of different tools, and you understand when you need to, when you can use them and when you can't.
Right.
And the digital technology world has really enhanced that whole concept, because you can do so many. With an intraoral scanner, you can do so much stuff. It's just shocking.
Right.
Even in kids when that have severe transverse, their jaws are just not wide enough, and they're already 11 and 12. They're already 12 years old. It's 90. Sagittal. Their front growth is done. Their width growth is done 90%, and you can only tip the teeth so far. So you need more orthopedic remodeling again, and being able to put actually mini implants in. It sounds brutal, but it's not into the palate and split that suture, which is still pliable at that age, so they're wide enough and the bone grows through that. That's done totally with technology. It's a scan inside the mouth and a 3D X-ray around the head, and the lab takes those two scans, merges it together, fabricates the appliance, and it's fully guided.
Wow. And it's completely individualized and personalized for that.
Yeah.
For that patient.
Yep.
We've come so far from
Yep.
the ugly braces we had to wear as kids, right?
Yep. So there's, and this is again growing bone. Everything
Yeah.
is about growing bone.
Right, right. Yeah. So this is really fascinating, and I am so grateful that you took the time to come and speak to us today. And um, do you have a message for my audience, about how to reach you, or what you would hope how they would learn more about this?
Yeah.
What's the takeaway you'd like my
Well,
audience to
the
have?
takeaway is, there are not many of us doing this. What we're trying to do, those of us that are in the academic part of this and doing this longer, is get it to be able to be taught in dental schools or even in pediatric dental residency programs, which is not taught in. The hospital where I'm on staff has one, and it's not taught there except by me. It's taught, and
Right.
that's only because they have me there, not because it's part of the curriculum. So so that's the first thing, I'm in practice on Staten Island. I'm easy to find. You can give out my email address, and
Yeah, I'll put your website in the show notes for sure.
yep, we're happy to help anybody. And again, what we've been doing again for our community is any of the parents of these kids that have any questions, if they send us, and my staff knows what they need, send us some photographs, send us a 2-minute video of the kids sleeping, and fill out a little intake questionnaire for us. I will even, at no charge to the patient, do a 20-minute Zoom with them and tell them, what I think and what some of the best options
Wow.
are.
That's so generous of you. Thank you.
Yeah, we've been doing that. We've been doing that as well.
Yeah. And we have to get more people trained. So how do we get it to be the curriculum? That's the
Well,
magic question.
well, again, there's the professions are interesting because even the American Academy of Orthodontics has had a lot of pushback. And about 1 in 4 orthodontists now are airway-centric, and they practice this way. About 1 in 4 in the U.S.,
Okay.
which is
Yeah,
way
yeah.
better than
Yeah.
about 10% about 10 years ago.
Yeah.
And at least they have some of the concepts, but it's not from the training programs.
Right.
It's from people that are on the outside. It's from people like Kevin Boyd,
Right.
and people like my mentor Barry. Kevin was one of my mentors, but Barry Rayfield.
Yes.
Who's an amazing orthodontist.
I know
in
Dr.
Clifton,
Barry.
New Jersey.
Yeah, I've been to his center for programs
Yeah.
there. Yeah.
Yeah.
And of course, organizations like PANI.
Yep.
Right, where we
was
get together, and that's really fascinating. And
Yeah,
there are so many organizations and conferences now where people can learn if they're open to it. But I remember when my youngest daughter was finishing up her orthodontia at an orthodontist whose name I won't mention in Staten Island. And I was just learning about tongue tie is related to breastfeeding. And I asked him about tongue tie, and he went, that doesn't do anything. So that's, and this was about like maybe 15 years ago.
Yeah. Well,
So we have a long way to go.
A long way to go. One of our biggest problems is that the pediatricians, and it's not their fault. There's zero training in their specialty program. So it's been a very difficult, the one profession that's not been to any of our airway roundtables yet. We don't have one pediatrician.
I know.
We have orthodontists, we have ENT, we have sleep physicians, we have everything else. We don't have
psychologists. So we have everything,
but not a pediatrician.
Not a pediatrician.
And that's concerning.
Yeah.
And so this is challenging. I mean, and it's an epidemic. I mean,
I think we have to get the message to parents who are the consumers.
That's where we're going with this. Yes.
Yeah. It's got to be consumer driven.
Yeah. Videos like, YouTube, Finding Connor Deegan, which is an amazing video.
Yes.
Kevin Boyd treated that patient now 13 years ago.
Yeah.
And the parents group did an amazing job of putting that video together.
Yes.
And that's been
is that on YouTube? Maybe I can link to that.
It's on YouTube. Yes.
Connor, what's his name?
Finding Connor Deegan, Deegan. It's a 5-minute video. We show it to parents. We show it to parents every day.
Functional therapy course I took.
Yeah. We show it.
There's not a dry eye in the house after that one.
And this kid was 11 years old when they first figured it out. And that's kind of down the road, but he had a great result.
Yeah. Well, Dr. Acker, thank you so much for being here. Keep doing the great work. I'm so
It was a
grateful.
pleasure. All right, it was a pleasure, and I look forward to doing this at some other time. Yep.
Yes, absolutely.
Okay.
Thank you so much for listening to this week's episode of the Tongue Tie Experts podcast. Check out the show notes for useful links about the topics we discussed and for ways to follow us on social media. Please subscribe to us on your favorite podcast app. And if you enjoyed listening, we'd love it if you'd rate, review, and share with your friends and colleagues. Thanks so much. Bye-bye. Have you ever wished you could help that mom who is questioning if she has enough milk? Ever wanted to either reassure her or know when to refer? As a lactation consultant, I created the program Understanding Milk Supply for medical and birth professionals to help you to feel more confident in those exact situations. This affordable, recorded video mini course is open to anyone who works with pregnant or breastfeeding families. It's a particularly valuable opportunity if you're an SLP or an OT who wants to gain an understanding of how breast milk is made, or a dentist in the field who is often the first-line provider for tongue-tie treatment. The function of the infant at the breast depends on milk supply. Even if care of the mom isn't in your scope, there are basic principles that you can learn that may rescue a family's feeding goals. In Understanding Milk Supply, I teach you what red flags to look for, when to refer, who to refer to, and how to advise the family in the meantime. And there's one LSERP included for lactation professionals. Go to www.tonguetieexperts.net/milk supply. The link is clickable in the show notes. And as always, you can use coupon code PODCAST15 to save 15% off this and all Tongue Tie Experts courses. Thanks so much.